Welcome, everybody. Rush University Medical Center Division of Nephrology Renal Biopsy Conference for February 22nd, 2024. No CME code today. This conference is being recorded and, as usual, will be uploaded on our YouTube channel. Please join the YouTube channel, and if you're not on our email list, message us and we'll put you on there. We'd like to have as many of you and your colleagues join us as possible. We have nothing to disclose, as usual, and our patient confidentiality is always protected with appropriate changes in the protocol. Yesterday, I tweeted out that we were going to have a sing-along, and I made a joke that will it be Dr. Corbett singing Blackbird or myself singing Queen? I know a lot of our fellows, ex-fellows, are on the conference, and they will get the Blackbird joke. It's pretty classic. But indeed, I'm not singing Steve's not singing Blackbird. Steve's in Paris. He's not singing Blackbird, and I'm not singing Queen. But we're going to have a sing-along and wish Dr. Glassick a happy birthday. He turned 90 on February 4th. So everybody, unmute yourself. You have to unmute yourself. We allow you to. I'll give you a second. Turn your videos on, please. I want to have this screen full of faces with moving lips. So give it a little more time. Come on, put your face on. Unmute yourself. I'll start it in a few minutes here. I'll let you know. It's Dr. Corbett is coming on, live from Paris.
Corbett likes Paris.
All right. I think we can, we'll start. Anybody else want to put their face on? Let's get as many people as possible.
I'm in the hospital. This is going to be a little embarrassing.
That's okay. Bill, I've heard you sing. It's always embarrassing.
Oh, that's a good point.
Nilu, come on, Nilu. Put your camera on. Oh, wow. Look at this. Wow. Never seen this before. All right. I'll start on three. 1, 2, 3. Happy birthday to you.
Happy birthday to you.
Happy birthday, Dr. Glass.
Dr. Glass.
Happy
birthday to you.
And many more.
Hey, thank you all very much.
Dick,
What a surprise.
You've made this a better world, and it's certainly made it a better conference. So look at him. He's on front stage up there. How'd you pull that off? Okay.
Look at that, huh?
Make sure we get a
You guys
screenshot
are
of that.
something else.
Yeah. That's Dr. Baxi from Baxi Productions.
Yeah.
Well,
Thank
welcome.
you all very much.
Yeah, it's great. It's so wonderful. We're just so pleased for you, and thanks for being part of this. Let's move on. We do have a conference today. Dr. Baxi has a case. It's an interesting case with a lot of interesting twists, as we often do. Rarely is anything straightforward anymore. Hey, Steve. Bonjour.
Bonjour.
If you want to put the protocol on.
Yep. I'll be reading it. Give me a second here. Is that PowerPoint?
Yeah.
Give me a second here. All right. Share screen. There we go. All right. I'll be reading the PowerPoint, the protocol. Let me send out the PDF versions for those who may not be able to read the screen as much. Give me a second here. So you'll have the PDF of today's case to review. All right. So today we have a 76-year-old woman who we were consulted for proteinuria on the inpatient side. In terms of her history, she has a history of classic Hodgkin's lymphoma, which was diagnosed approximately 8 years ago. And I go through over some of her prior oncology, hematology treatment below, which we'll get to. She also has a history of type 2 diabetes, about 15 years. She is not insulin dependent. She does have neuropathy, but no known retinopathy. Hypertension for about the same amount of time, and a seizure history. After her response to initial chemotherapy and immunotherapy 5 years ago, when she was diagnosed with Hodgkin's lymphoma, she was taken off all treatment with plans of close monitoring. She basically went into a partial remission, and she had regular CT scans that showed no progression of disease. She was getting this regularly, seeing her hematology oncologist every year with CT scans, and so she's been pretty stable. Now, about 3 months prior to our current presentation, she presented to the hospital with lower extremity swelling. And at that point, she was diagnosed with a new right lower extremity DVT. She was started on anticoagulation, and unfortunately, about 3 weeks later, she was again admitted for severe anemia that was found on outpatient labs. Her hemoglobin was down to 6. At that point, there was concern for GI bleeding since she was just started on anticoagulation. And a full GI workup was done. She had scopes, no evidence of active bleeding or any other source of bleeding. And so then there was concern with her DVT and new anemia of lymphoma relapse. And so she underwent bone marrow biopsy that unfortunately showed that she had a significant relapse and withdrawal of 80% of her bone marrow on bone marrow biopsy. With limited options per the hematology oncology team, she was started on pembrolizumab, a checkpoint inhibitor, 1 month prior to the current presentation. Now we are at the time of consult. Our team is seeing her. She's now admitted after starting checkpoint inhibitor therapy about a month ago. She comes in with shortness of breath through the emergency room. She's found to have anasarca exam, and this has been progressing over the last 2-3 months. She gets X-ray imaging that shows bilateral pleural effusions. She did have CT PE protocol that showed no evidence of a pulmonary embolism. Her labs at this point showed a creatinine of 0.75. Albumin was down to 1. Previously, until the recent admission, she was 2.7 to 3.1 on average. Her hemoglobin was back up to 8.8. Her UA showed 3+ protein, otherwise had inactive sediment. Proteinuria studies, she had a UPC of 11 grams and a UAC on the same sample of 6 grams. I mentioned the CT imaging already. She did have abdominal imaging that showed no hydronephrosis. She was started on diuretics. And that's kind of where we were. In terms of review of systems, I've kind of gone over all this already. Past medical history, she did have this interestingly remote history of marginal zone lymphoma in her spleen, splenic, and that was, she had a splenectomy done about 25 years ago, never required any therapy, and she really had nothing until she was diagnosed with Hodgkin's lymphoma again 8 years ago. The rest that I've mentioned. In terms of her prior chemotherapy regimen, she had received initially doxorubicin, bleomycin, vinblastine, and dacarbazine. After that, without a full remission, she underwent a clinical trial, and she was placed on combination therapy, including 2 checkpoint inhibitors, and she is currently on pembrolizumab. She's on allopurinol. In addition to that, she's on pantoprazole 40. She's on Keppra, metformin, nothing really other. She has a history of mild hypothyroidism, for which she takes Synthroid. Former smoker, she quit many years ago. She has overall 30-pack year history. No other drugs, no known kidney disease in the family, although her sister has lupus. Exam-wise, blood pressure, 130/80. Her BMI is 32. She was actually, when the time we saw her, she was feeling a little better. She was not in acute distress. She had some bibasilar crackles, but overall was satting okay on room air. Major thing to note on her exam was just her anasarca, and she had edema all the way up to her thighs. There was 3+, no rashes, no other cardiac findings. Lab studies, her sodium was 136, potassium 4.0, chloride 104, bicarb 28. BUN 18, creatinine was 0.75, as I mentioned. Albumin was 1. Her LFT were all within normal limits. Her cholesterol panel was checked. Her cholesterol was 120. Total cholesterol, LDL was 48. HDL 51. Her white count was normal. Her hemoglobin had gone over. Platelet count was also normal, and she had an MCV of 94.3. There was a serological evaluation done that we started with that was really unrevealing, as listed here. Nothing was positive. UA, as I've already mentioned, gone over. No blood with nephrotic range proteinuria, and then a CT-guided percutaneous biopsy was performed.
Any questions for Dr. Baxi?
I know you said that a month ago or so, her albumin was 2.3 or 2.7, something like that. Now it's 1.
Yeah. So it'd been,
Okay.
2.7 about 3 months ago, and then slowly trended down to 1.1 or 1. Yeah, down to 1 now.
And the first time we've got urine studies is the current admission. We don't have proteinuria.
Yeah, we have
or
one set
anything.
of urine studies from about a year ago because she was diabetic, so she was getting UAC ratios every 6 to 12 months. The last one, unfortunately, was a year ago, but the urine albumin creatinine ratio on that was normal.
Hmm.
And I think I put that the UAC. All right,
I may have missed that.
UAC,
Sorry about that.
I forgot to mention that's important. The UAC was 1 year ago was normal.
Thanks.
Great. I think we're going to start with a poll here. So poll number 1, what do you think this patient has? Do you think this patient has an idiopathic podocytopathy? And granted, I mean, pathologically, these things may look very similar, but I'm talking about what you think this patient clinically has. An idiopathic podocytopathy, a lymphoma-associated podocytopathy, a checkpoint inhibitor-associated podocytopathy, a malignancy-associated membranous, or a paraprotein-related lesion. It's number 5.
And of course, the poll did not register 5, so if you
Yeah.
choosing 5, please put it in the chat. Or, oops. Oh, sorry. No one else should be touching the poll. Give me a second here. I'm going to relaunch it. Give me a second here. See if I can. All right. Go ahead and vote.
Still not there.
Yeah, I know. We'll have to put it on the
That's
in the
fine.
chat. Yeah.
That's fine. That's funny because people saw the first votes and now they're voting again, and they're voting.
Yeah.
Good experiment.
Yeah, it was a good experiment to see how people change their vote. Suddenly, everybody votes what the majority was before.
Social experiment.
Yeah, this is not a biopsy conference. This is a sociology experiment. We're gonna publish this. We've got you tracked, so you'll be called out for changing your vote.
All right. Well, it's pretty.
Yeah, that's good. That gives us an idea. Yeah. So our number 1, at about half, is a lymphoma-associated podocytopathy. We have 1 person with idiopathic podocytopathy. We've got several that think it's this checkpoint-related podocytopathy, and several people think it could be a malignancy-associated membranous. So I'm going to hand this over to Dr. Gashti, our on-site onconephrologist, to give us the first stab at what he thinks is going on. Casey?
Okay, so this 76-year-old with history of classic lymphoma, previously in partial remission, now relapsed, was started on pembrolizumab, is now presenting with pretty severe nephrotic syndrome and hypoalbuminemia, and complicated by development of venous thromboembolism. On the face of it, this looks like minimal change disease. There are some features that are unusual, aka the fact that the cholesterol is not very elevated, but the low albumin and the association of minimal change with hematological malignancy, specifically Hodgkin's lymphoma, is there. I believe that the cases of minimal change associated with Keytruda or pembrolizumab is very, very rare, like in the sense of case report. So although it's going to be difficult to prove whether this is due to the drug or due to the disease, just from a rarity standpoint, I would think that this is a secondary nephrotic syndrome due to the Hodgkin's lymphoma. Membranous is also on the differential. This is again nephrotic syndrome, so we'll see. That's why we do the biopsy. You know, usually see membranous with solid tumors, but you know, it could also be the case. The fact that the cholesterol is not extremely high pulls me a little bit away from minimal change, but not enough for me to put membranous as the number one. So I'm still going to say that we're going to see diffuse foot process effacement without any immune complexes that would be consistent with a minimal change disease. And we're going to have to discuss if this is the lymphoma, this is the drug. I think this is going to be the lymphoma.
Membranous has to be pretty unusual with lymphoma,
The blood clot is more common in membranous.
I see, yeah.
Lack of significant hypercholesterolemia. We don't have the mandate of the urine albumin creatinine to protein creatinine ratio of over 90%, which points more towards membranous. There are some features that seem a little unusual, but again, I think that, I mean, this is the elephant in the room is this Hodgkin's lymphoma, and then this minimal seems like a nephrotic syndrome. So I'm gonna sort of connect the two together.
Yeah, no, I think those are all good points. It's a couple which I hadn't really thought about, you know, the selective proteinuria perhaps and the clot. I think those are good points. I just don't, it's not something you typically would put together with a blood cell tumor. But yeah, that's really good. I'm glad you pulled it in a little stronger. The cholesterol is interesting. We're not going to go over that. We've gone over that many times, and we'll see in the end if that helps us or not. But it's not even, it's very impressively normal. Dr. Kramer, you want to tell me what your thoughts are, Holly? Welcome, by the way. Holly maybe stepped away. Oh, she's there. Unmute
No,
yourself.
I'm right here.
Okay, great.
The fact that the albumin is so low does make me think that this could be like a Nils disease, and I think it's probably related to the lymphoma.
So Nils disease, that's a term I don't think we've used in 2 years of biopsy conference. But I guess that's what they call it down the road at Loyola. Dr. Reen, what do you think's going on?
I think it looks like a podocytopathy related to lymphoma, but I wouldn't rule out immune checkpoint inhibitors also, although that's bottom of my list, but I think it's a lymphoma-associated podocytopathy.
Bill, what are your thoughts?
Yeah, I think that's number one, but I would say that, you know, as far as the cholesterol, you know, she is on a statin. I don't know how long she's been on that. I wouldn't think that it would take a hyperlipidemia of total cholesterol 500 down to 120, you know, if it was from nephrotic syndrome. And the other one we kind of brought up in the past was amyloid may not give you as much hyperlipidemia as minimal change or even possibly membranous would. And so you know, that's in the differential for that as well. But I kind of feel like this person's on a statin and maybe it just even hasn't had enough time to go up yet, and minimal change is still more likely. The other thing I would add is that if it is membranous, maybe we would be invoking a PLA2R negative, like a NEL1 positive membranous. You know, one of the ones that's more associated with malignancy. I'm not quite sure if that was mentioned or not. And if it's due to the checkpoint inhibitor, obviously we usually see AIN as the most common lesion, but these glomerular diseases have been reported as well. And so it's going to be kind of hard to tease that out, but I think most likely it's this podocytopathy primary associated with lymphoma.
Immune checkpoint inhibitor, especially, I can't pronounce the drug, so I'll say the drug mentioned can cause NEL1 membranous. It has been described recently, so it's not only malignancy here.
Yeah, that's a good point. And I'm glad you brought up, you know, we had put in the poll, you know, a paraproteinemia related renal disease, or kind of getting along the lines, it's got a long history of lymphoma. This could be an amyloid or it could be a paraprotein. Nobody asked if there was a paraprotein in the blood. Dr. Baxley, was there a paraprotein?
I actually included it in there.
Oh, is it there? I'm sorry.
Done,
Oh, it's there
yeah.
now.
I jumped
Yeah.
the gun.
Okay.
Yeah.
It was it. Yeah, you added it. Okay. Yeah. So that's kind of, and you know, you may not find it regardless. So I think that's why that was in there. Who knows if that would have been left up in the poll to actually vote for, if you would have got many votes. But anybody else have any thoughts?
Roger,
Yeah, Dick.
if this is a diffuse podocytopathy, due to Hodgkin's disease. How do you explain the poor selectivity of the proteinuria? The albumin to protein is ratio is not very high for minimal change disease. And I must say, I'm in Bill Whittier's camp, an LDL of 48 with a patient with severe nephrotic syndrome due to minimal change, diffuse podocytopathy. Boy, I've never seen it, but I suppose it could happen. I'm in the amyloid camp. Serum
Ah,
amyloid A with AA, secondary amyloid, is certainly one of the lesions in longstanding Hodgkin's. I would say that should be in the differential.
yeah, that's, I'm glad because that was brought up
Yeah,
kind of at the
it's
end there.
AA amyloid. It's not a light chain amyloid.
Yeah, no, that's
You
true.
wouldn't
Yeah,
expect
yeah,
any
yeah. Just chronic
peripheral
inflammation, exactly. Yeah,
monoclonal protein in
yeah,
the
yeah,
Hodgkin's
yeah,
disease
yeah,
associated amyloidosis.
yeah.
Now, Prabir, did the nephrosis develop after she received Pembro, or was there any temporal association?
It sounded like, based on the history, again, we don't have that UA from the time of her DVT, but it sounded like around that time is when it really started. So slightly before the pembrolizumab. But it's hard to tell.
Well, I think it's time to take a look. Put the wheel up and we'll give it a spin. Ah, Dr. Coleman, Michael Coleman, first year fellow.
You sure it doesn't say Steve? Okay, just making sure.
No, it doesn't say Steve this time. Yeah, you threw me off for a second. I thought I couldn't read my fellows' names. Got scared.
Well, there's an inside joke that he thinks that it's weighted. So
Yeah, every fellow. There's always some fellow thinks they're being persecuted, and that we wait.
Yeah.
That it's just kind of pathetic. But
All right.
we try to support them regardless.
Michael, give me a second here. I'm going to give you control. You should be able to unmute yourself.
Yeah, can you hear me?
Yep. Oh, let's see what's going on here. That's not it. Give me a second here. I was able to do that cool thing with the happy birthday, but now I'm having issues with the basic stuff here. Give me a second. See if I can get this back up. Give me a second. For some reason, it closed on me.
Got the
There we go.
the birthday virus in your computer.
No, there we go. There's two open, that's why. There we go. Give me a second here. Mike, I'll give you control. Go ahead and click. Yep, you're controlling the screen. Remember, there's a lag sometimes.
There we go. Okay. Oh, sorry about that. Okay, so this is trichrome stain of cortex. And we're looking for how much fibrosis there is. This kind of like light blue. I would say maybe like 20% of the cortex has some fibrosis.
Yeah, that's right, Michael. That's what I said. It was kind of, you could see kind of little patchy areas, about 20%. Right, spot on.
Right. Okay, this is PAS stain. And then we have a glomerulus here. And the capillary loops look pretty open. I feel like this large white space is probably just the way that it was cut, I would imagine.
Yeah, just some retraction artifact then.
Okay. But otherwise, I don't see, I mean, I don't see any hypercellularity here. Only like a few nuclei between each capillary loop. I don't know if this is any mesangial expansion here, or again, just the way that it was cut.
That's right at the hilum.
Okay.
Yeah, that's where it's attaching. Yeah, in fact, just to the right, yeah, a little arterial, right at the high, yeah, right there, yeah.
Okay.
Apheresis.
And then looking at the tubules, maybe a little bit of sloughing here, but otherwise look pretty good.
Yeah, I see brush borders there. Yeah, they look okay.
Yeah, that's about it for this one. Another PAS stain, a glomerulus.
I think we need I think we need a sharpener knife here. It's just destroying the glomeruli as we cut them.
The capillary loops look pretty open to me again. Maybe like a little bit of mesangial expansion here, not entirely sure.
Yeah, there is some mild mesangial expansion throughout.
I don't see any hypercellularity really. I mean, maybe, no. Looks like maybe there are 4 lymphocytes here between the capillaries. So yeah, it doesn't look like there's much hypercellularity. I don't see any like other abnormalities really. And I mean, a little bit of sloughing here with the tubules again, but
And it
nothing.
seems like the PAS stain is not weekly. This is a normal intensity, David.
Yep, yeah. Nothing that looks weakly positive or kind of amorphous like amyloid.
Another PAS stain. This glomerulus though, I mean, this does not look like the others. This is maybe some mesangial expansion or scarring here.
Yeah, it's consolidated and segmentally scarred. There's
Okay.
no open loops through that area. And then if you look at the right half of the glomerulus, you still have open loops throughout that area. Yeah.
Yeah. Again, I don't see much hypercellularity.
Yeah, well, that's an area of scar. Yeah.
Scar.
Yeah, down at the bottom half is all segmentally scarred.
Okay.
Yeah.
And then
those are globally sclerosed glomeruli. Two on the left, and then one up on the top of the screen. Yeah.
Okay.
16 out of 35, so half globally sclerosed in the biopsy.
Okay. And again, the tubules look pretty okay to me.
Yep.
Another PAS stain, another, it looks like a almost globally sclerosed glomeruli here.
Well, you see, on the left side, I still see some open functioning loops of the glomerulus. Yeah. See that area isn't scarred. That's still functioning. So another segmental scar.
Another segmental scar. Okay. Is this another globally sclerosed
glomeruli?
Yeah. Okay. Yep. And then here too. Okay.
Yeah. This is nice. It shows kind of like that staining, although we don't have any nodularity. I know amyloid's on the differential, but you can kind of see how equally, I think as Dr. Weider had said, how equally staining, the mesangial area is with Bowman's capsule.
Yeah. Okay, so this is an H&E stain. And this looks like a scar also, segmental scar. But
yeah,
these
several had segmental scars in the biopsy.
But these capillary loops here look pretty open. And then yeah, the tubules again look pretty normal to me.
Yep.
Michael, you had commented a lot in the PAS about cellularity, and it's really difficult to even try to do that. But you go back to this one, you can really get with the H&E here, you can really get a better sense of the cellularity. And like you pointed out, there's a couple areas. It's not super impressive, but.
Okay, and then this is the silver stain. We're looking for spikes and holes, and I don't see that here.
Yeah, they look smooth and yeah, without spikes or holes.
Okay, and this is immunofluorescence, which is clearly positive for IgA. The membrane, or I'm sorry, the mesangium, I apologize.
Yep.
And then kappa and lambda are also positive. And the
yeah, equally positive. There's no monoclonal staining.
Okay, and then this is electron microscopy. So the urine space is here, and then the blood space is here. And the podocytes, it looks like here they are totally effaced. Here they look okay to me. Maybe a little bit of effacement here. And then looking for deposition in the GBM, I don't really see deposits along the basement membrane
Yeah,
here.
yeah, we didn't see any on the fluorescence either, but just below your arrow, yeah, you're on a deposit. If you, yeah, right there, there's a mesangial deposit.
Okay.
Yep. And then in the mesangial area in the top right, there's another capillary. Yeah, yeah, there's some more deposits in there.
Okay.
Yep.
And then again, this is the urinary space. This is the blood space. The podocytes here, they look okay to me.
Yeah, overall, they were only focal partially effaced, about 25%.
Okay. And then in terms of deposits, again, I mean, I don't really see any here. Is this a deposit?
Yeah, yeah, there you go. Yeah, that's a mesangial area with some electron dense deposits.
Okay. Right. And this is a really close-up view. Is this a deposit?
Yeah, yeah, high power of the mesangial area, and there you go. Yeah, there's some deposits there. You can see they're not organized.
Yeah. Okay, cool.
David, you did a Congo red, right?
Yes, negative.
Yeah. Okay. So, Michael, what's your diagnosis, Michael? What's your pathologic diagnosis?
On immunofluorescence, it was IgA positive, so this is IgA nephropathy. There was some podocyte effacement, and maybe a little bit of ATN.
And a lot of
and focal segmental glomerular.
a lot of segmental scars, yeah.
And
well,
you didn't show us C3.
C3 was negative.
Ah, a negative C3?
Yeah. Well, or just trace. Yeah, it wasn't significant.
That will require some discussion.
That'll require some head shaking on my part, because I'll be glad to hear what that means.
Yeah, that'll require some listening from.
That's what I really meant to say, Bill. I joke, but that's exactly right. Before we talk about it, we're going to throw a poll out here. I think that's poll number 2. So, based on what we saw, at least, how would you treat this patient in addition to all the non-immunologic aspects? So number 1 is treat as IgA nephropathy. In other words, you think that the primary process here is IgA nephropathy. Whatever that treatment is, for you today, that would be number 1. 2 would be CNIs. 3 would be rituximab. 4 would be steroids alone, and 5 would be just observed with lymphoma treatment.
Some more votes. Don't worry, we can't see. Wait for a few more here. Perfect. All right.
So the majority is saying observation, and then the rest is pretty much spattered about. Nobody likes CNIs. CNIs have really fallen out of favor. I think this conference has been somewhat responsible for that, as well as ASN communities. Doesn't seem to be. It's the non-favored treatment these days. The others are spattered amongst treat as IgA nephropathy, rituximab, or steroids. So It's really hard to say, you know, what you would pick there. You kind of have to decide what you think is actually going on. So let me hand it back to Casey. What do you think is going on, Casey?
I'd rather listen to Classic tell us what's going on. I don't know. I mean, I have not seen or heard of IgA association with with lymphoma. So that's a little puzzling to me. There was a lot of, I mean, that first trichrome, there was a significant amount of glomerular obsolescence and dropout. Like 50% of the gloms were completely gone, and only about 20 to 25% of the tubular interstitial area was gone. So this seems like she's already lost quite a bit of function. As far as treatment is concerned, it was mentioned in the protocol that because they didn't have a choice, they put her on pembrolizumab. So I'm not sure what that means from a lymphoma treatment standpoint, but whatever we end up doing here is going to have to tie into that, because, you know, checkpoint inhibitors and then putting steroids on board or any other type of immunosuppressant is going to negate the effect of checkpoint inhibitors. I mean, that's the whole point of revving up the immune system to attack the cancer. If you try to immunosuppress this patient, that may actually cause secondary harm by not treating her lymphoma. So I'm with the camp of observe with lymphoma treatment.
And the IgA, innocent bystander?
I don't know. I cannot tell if she had IgA and this is a superimposed lesion. It seems to be there's a reference with secondary IgA and lymphoma. I have not seen that. If that's the case, then you just treat the lymphoma if it's truly secondary. But I don't want to give Rituxan or steroid here if this is going to cause problems with the lymphoma treatment.
You know, the thing about IgA nephropathy, when you look at secondary causes, it's a very long list, and the same thing is true when you see segmental scars. I do remember years ago, Hodgkin's associated with segmental sclerosis. I'd forgotten that, but you know, you think about minimal change. But I threw a reference in there. It's a little bit up in the chat that I don't think it's something we see commonly, but I think it is well described. It was pointed out in the chat as well. Dick, what's your C3 story?
Well, in true primary IgA nephropathy, complement deposits are almost always seen. In the lanthanum form of IgA deposits, they're seen in many normal kidney biopsies. And perhaps Mario wants to chime in here because the Houston group, Suki and his colleagues, have shown that as many as 15% of normal donors will have IgA deposits, often without complement, without any findings. It often goes away after the kidney is transplanted to a new recipient. But I think just IgA deposits without any complement in a patient who has no history of hematuria, no proliferative lesions, no endothelial cell capillary hypercellularity, and only sclerosing lesions, I would not think that this fulfills a diagnosis of IgA nephropathy. There may be IgA deposits, they may be completely coincidental, having nothing to do with what's going on in her kidney and the reason for the high degree of glomerular obsolescence. I would say secondary FSGS is the more likely diagnosis than secondary IgA nephropathy, and I wouldn't put too much credence on the IF.
Yeah, I think that's those are all good points, and you know, there's a lot of IgA floating around. Dr. Suki, we have you can unmute yourself. Dr. Glassick had referred to some of the work you did finding IgA in normal donors. Are you able to speak on that?
Yes, Dr. Glassick is almost perfectly at the point. Actually, we reported some 19% of kidney biopsies on living donors as well as deceased donors. have IgA. As he mentioned, infrequently C3 and minimal sclerosis. So and it did disappear in subsequent biopsies of those kidneys after transplantation. So that's very accurate.
Yeah, that's really high. I had no idea it was, anywhere close to that.
Incidentally, the distribution in those kidneys mirrored the distribution of the disease in the general population. We saw it mostly in Hispanics and Asians, with less in whites and least in blacks. And this patient being discussed today is black, so that's much less common, but certainly seen.
Do you remember if those if the patients that were incidentally found to have IgA, the donors, if they had hematuria? This patient had no hematuria.
Well, these are all donors who were worked up, and there was only one case where the donor had hematuria and had a GU workup, which was negative.
I see.
So
Yeah.
one donor only out of something like 800 biopsies we looked at.
Dr. Rubin, your hand is up. You never need to raise your hand, Mario. You could just speak up.
Okay. So I just wanted to point out that when the literature on the association between IgA and checkpoint inhibitors is reviewed, the three larger series are the one from Houston, from MD Anderson, the one from Kennard-Jaberi, and the one from Columbia. They have all reported IgA in association with checkpoint inhibitors. What I don't recall is whether there was deposition of C3 as well, but the data is there. Also, there is at least for primary IgA an association with FSGS, which has also been reported. And I still think that this is likely to be a checkpoint inhibitor associated IgA with a touch of FSGS that it has been reported. So we'll see.
Do you think I'm sorry.
The treatment in this case will be an in-depth discussion with the oncologists regarding what to do with the Pembro if we think that that's the reason for the illness.
Do you think that the IgA is just sitting there, or do you think it's actually doing something?
I think it's doing something.
Okay. Dr. Glass, if you had said secondary FSGS, do you think this is related to to the Hodgkin's, or do you think it's just?
Well, that's certainly on the list. Many kinds of malignant lymphomas can be associated with a lesion of FSGS. I don't think this is primary FSGS because there's only segmental foot process effusion. This is not a diffuse podocytopathy. It's not minimal change disease. It's not primary FSGS. The patient has Hodgkin's disease and a biopsy compatible with a lesion of FSGS, so I would make the possible connection. But that doesn't mean the patient should be treated for FSGS. It would mean the patient should be treated for the underlying disease as best as can be done. But I must say what Mario said, that the immune checkpoint inhibitors are really kind of a confounding feature here. Makes it hard to interpret, but this disease has been going on for a long time.
Dr. Radby, if I remember correctly, nivolumab has been reported as IgA nephritis, and I think I remember pretty well. There was C3 deposition in those patients.
Yeah, I mean,
find the
it's-
reference and post.
Yeah, that's the problem. There's like, it's like this bunch of arrows, and some of them point away, and some of them point towards um, a single kind of approach, and it's not easy to. Occam would not be happy today, I don't think, if he was around to call on. Although I hear he's a very good singer. Dr. Baxi has a few slides. Maybe he could tell us what his thoughts were. I know we waited a while for the EMs, and we pretty much had assumed the EMs would be not what they were. We just kind of figured this had to be a diffuse kind of podocytopathy. And then when that came back, it was like a huge surprise. And he's been trying to put it together since as best he can. So Praveer, what do you got for us?
No, I'm glad everyone else is a little puzzled too. I still can't explain the presentation of the nephrotic syndrome. I mean, this was proteinuria, anasarca, in the podocytopathy. There's no podocytopathy. So, this is what I had, and I'll kind of go through my thought process and a little bit of the stuff I gathered from doing some reading. A lot of stuff, as always, has been mentioned already, but I'll try to be brief on that stuff. But we have this patient had nephrotic syndrome. She had preserved EF, and again, although I don't know the exact timeline, she said it started around the time that the DVT began. So, and that's the time she was diagnosed with the relapse. But before that, she really didn't have any edema. So this is relatively new onset. The kidney biopsy showed us an IgA if it's, again, either incidental or it is, and then you can give it a MESI score if you think this is, pathologic. And we had segmental scarring. We had a FSGS pattern of injury. But the biggest thing, as Dr. Rodby mentioned, is that I thought it was going to be diffuse podocytopathy. There's no other way. And then the question was this checkpoint or lymphoma? So that's kind of, when this came back, now the question is, how do I tie the focal foot process effacement along with this IgA? Is it incidental from the lymphoma? Is it a checkpoint inhibitor? Or is there something else? So this was already mentioned. This is one of the reviews of checkpoint inhibitor induced glomerular disease. And when we think of checkpoint inhibitors, we think of primarily AIN, right? We think of AIN, ATN, and mostly tubular interstitial disease that can happen at various time lengths after the initiation of these agents. But, there is data on glomerular disease. We know that checkpoint inhibitors really can do anything in the kidney, but glomerular diseases, when we look at them, and this was a pool of 27 studies, again, these are all case reports, case series. They had 45 cases of biopsy proven immune checkpoint inhibitor associated glomerular disease. And the majority of these were posse-immune. So that was the most frequent one. Renal vasculitis was the majority. A very close second was podocytopathies, and this included both FSGS and minimal change pattern of injury. And finally, they also had, which was interesting, I didn't know, is a subset of patients who had C3GN. And not surprising that these patients didn't do well overall. When we go towards our checkpoint inhibitor regimen, it's usually for patients who have pretty significant disease, or as in this case, she actually was on a clinical trial even before for checkpoint inhibitors due to the lack of full remission. So there was some good outcomes, or overall, again, the overall patients, which is again not surprising. Now, we usually associated a lot of the anti-CTL4 agents with the renal effects, but we're seeing a lot more in the literature of the PD-1 and the PD-L1 inhibitors, such as in this case, causing more glomerular diseases. The median time from this series was about 3 months, but there's also a few cases that it happened months after discontinuation.
Yeah.
So, that timeline is so hard with these agents, and it really, unless you have every single data point, which we don't have, it's really hard to tease out.
And this was 1 month, right?
This was 1 month. Yep, 1 month.
And then 1 month is not out of the question.
No, it's not. There's a few that were
the range,
weeks,
right.
and that goes in perfectly into this one kind of goes into some of these cases who had podocytopathy. But if you go in, there's patients who had it after 4 weeks, 6 weeks. Now, on median was 3 months, but yeah, 1 month is not out of the question at all. These were the ones from this article that did have podocytopathies. Again, our patient didn't have this, but our patient had nephrotic syndrome. Our patient had focal segmental glomerulosclerosis, but again, really didn't have the diffuse podocytopathy. And I couldn't find if these patients here who had FSGS, how much diffuse foot process effacement they had. but in general, they were treated. A lot of them, of course, had nephrotic range proteinuria. They were treated with prednisone, and interestingly, a lot of them did do good overall in terms of initial outcome. But again, as I said, a lot of these, even though they had a remission, a partial or full remission, they end up having not a good overall prognosis. And this was only a subset of 11 patients. IgA, the next thing I saw, okay, well, there's FSGS. What is associated with IgA? And I know people have already mentioned there's IgA associated with checkpoint inhibitors. It's very limited. I couldn't find much. There's very few cases. This is one that went over 2 cases of IgA associated with checkpoint inhibitors. In this patient, actually, I don't know the full process of effacement here, but these patients had a lot more what seemed like active IgA than what we had in our case. But the one was with a combination therapy, and the other one was solo therapy. This happened about 6 weeks after. This was 12 weeks after. Now, in this case, this patient was already improving because this patient had been started on steroids. So by the time they did the biopsy, it wasn't really active in terms of what they were seeing. But they still had some residual IgA. So it is possible, is what I gathered from there. And this is also that's the checkpoint inhibitor associated. Now you go to what we've talked about, was it this related to Hodgkin's, right? Those were the 2 major things. Now, this is an article from Dr. Egan and Dr. Lewis that was published back in 1977 that looked at the different lesions with patients who have neoplasia. And sure enough, Hodgkin lymphoma was a subset of these. And the majority, as we mentioned, had minimal change, a membranous, and then secondary amyloid as well. This was also mentioned. There's very few instances of FSGS that we've already brought up, but again, I did not find any IgA associated with this, but although it can, we've seen, I think the case reports were non-Hodgkin's potentially, or just lymphoma associated IgA. So there's very limited data on that. So that really left me with what to do. Well, as I'm waiting for the EMs, I did not put her on steroids right away. And what we found was that, we diuresed her and she responded really well, which was the first step. As people mentioned, I had a long discussion with her hematology oncology team, and unfortunately, she has no other options. So her current checkpoint inhibition, I think that which Dr. Gasher had gone over, she has no other options. This is her last option. So they were not keen on stopping this. And so we continued. About 4 weeks after the biopsy, we had labs drawn. Her creatinine was still stable. Her albumin was up to 2 now. So it was down to 1, it's up to 2. Unfortunately, I was unable to collect a urine sample at that time. But clinically, which is the most important, which was really important for me, and of course her, was that she was feeling better and her edema had nearly resolved. So she said, and she's on, high dose diuretics, but really no edema. She said she has shortness of breath has gone away. And so based on this biopsy coming back and her clinical improvement, I elected to avoid putting her on immunosuppression for the time being. And for her general prognosis, we had to continue the CPI. Now, so how do I put it all together? I think that's the hardest part. To me, and this is how I did, I think the IgA for me was incidental. I know there's this association that I'm just learning about with the lymphoma. I think the IgA was incidental. I think this coincided with her lymphoma and relapsing. And I think the checkpoint inhibitor that was started a month ago may be stabilizing something. I think we're seeing improvement. And I think we caught her at the time of the biopsy with focal flow process effacement. And maybe we just caught her as she was improving, because her albumin is going up, her edema is going down. So we may just have biopsied her at a time that maybe stuff was improving. That's the best way I could put it together, because otherwise I can't really explain all her findings in one.
So you're saying that she probably did have diffuse fluid process effacement at some point, maybe 2 weeks ago, but it's already improving, possibly with lymphoma treatment from her checkpoint inhibitor.
Yeah, only because of the follow-up with her edema going away or albumin going up. I just think maybe we just caught her at a time where it was resolving.
And what do we think the chronic damage that we saw based on 50% glomerular sclerosis, what's that from? What do you think?
She has hypertension. She is Black. I mean, I could do genetic testing. She could have APOL1 potentially, causing segmental and glomerular sclerosis. She is, how old is she? She's above 76. So I would chalk that up to her other risk factors. She's had a normal creatinine this whole time, and I mean, this is 0.8 has been her. She's never had hematuria. She never had significant proteinuria. So I chalk that up to just chronic hypertension at FSGS for potentially APOL1.
Now, Pravir,
Well, the lesion in the kidney, chronic hypertension is not FSGS. It's global glomerulosclerosis.
And she had both of that, right? Yeah, she had that. And then on the FSGS, I would say maybe APOL1.
The focal and segmental scars, I don't think can be attributed to hypertension. Maybe to diabetes, but I doubt it. I think that's intrinsic to whatever process is going on that's causing the nephrotic syndrome.
Mario,
I think your notion that you caught her at the wrong time, that she was actually on the way of getting some kind of improvement, is a good one, because the foot process alterations can rapidly turn around in a matter of days or weeks. So that's a reasonable suggestion.
Mario?
Yeah, no, I just wanted to share with everybody this article that I have posted from a Chinese group. And in their series, 11% of their glomerular diseases associated with checkpoint inhibitors turn out to be IgA. So it's not that uncommon.
Yeah.
And again, I need to search the publications that I cited earlier and see what's the percentage.
Could that be because it's
again, you cannot get rid of the checkpoint inhibitor in this particular case. And, you know, I have discussed this subject with Ala Boutalaye. I'm sorry for mispronouncing her name, from MD Anderson. And she's a very gutsy lady. I mean, they have kept some of these patients on the checkpoint inhibitor and added steroids plus minus rituximab in some cases. Now, I'm not so sure. I must confess ignorance. I don't know what the outcome was of those particular patients with those drugs, but I personally would be reluctant to use them in a patient with a superimposed neoplasia, which apparently is fairly resistant to any other drug. So who knows?
Yeah, the IgA checkpoint inhibitor association makes me think of the IgA COVID vaccination. COVID vaccination association. You know, you stimulate the immune system, and they.
Hello?
Do you have dinner for tonight? Dr. Reen, please. You can mute yourself. Yeah. It just the two kind of go together in my mind, and it may be a little bit too simplistic, but it wouldn't surprise me because that was I believe that was the most common lesion after COVID vaccination was IgA nephropathy.
Yep.
So I like putting those together that way. There's a number of comments in the chat box that I missed. I apologize. And there's also a number of references. If you go back and maybe try to grab them or let us know and we could, you know, send us an email. We can probably send you that if you missed it. Any other comments? You know, I gotta say, you know, if you go back to the ABCs of this case, and there's something off about this cholesterol, and it just didn't make sense. Because they put so much weight on this albumin and the anasarca, and you think it's got to be a diffuse podocytopathy, blah, blah, blah. And if you kind of get back to basics, and then it's also pointed out that the non-selective proteinuria, I mean, the answer is kind of there. It's not as surprising, but I'm guilty into really buying into the fact that I was just waiting for the EMs to show a diffuse foot process effacement and kind of ignoring what, you know, a lot of you told us at the beginning of this conference. So, you know, lessons for everybody. Anybody have any final points they want to make? Holly, thanks for joining us. Thanks, everybody. Happy birthday, Dr. Glassick. Great comments and a great conference. And this is a Rush Renal Rules production that will be posted shortly on our YouTube channel. And until next week, everybody Stay safe.